Please help me to welcome our speaker for today. Dr. Kgomotso is a qualified medical doctor with the qualifications in public health. She has been working in the National Department of Health since 2001, where she was part of the team that coordinated the establishment of TB/HIV pilot sites, as well as the rollout of TB collaborative activities to the rest of the country. She's also the technical lead on viral hepatitis within the department, working with officials from communicable disease cluster and the HIV, STIs, and TB clusters. She has participated in the WHO reviews of the TB, HIV, PMTCT programs, and viral hepatitis baseline assessment. She previously worked in the medical legal services and as a district medical officer. She presented on TB, HIV integration and viral hepatitis at both the national, regional, and international conferences, AIDS, Union Lung, WHO regional and international workshops. She has submitted abstracts on IPT and viral hepatitis at the SATB and HIV conferences and the second Global Viral Hepatitis Summit in Brazil, which was held in 2017. She has published articles on viral hepatitis and TB, HIV, IPT integration. Please welcome Dr. Nhlapo.
Globally in 2020, which is a decrease from 7.1 million that was reported in 2019. An estimated 1.5 million deaths occurred in 2020 due to tuberculosis. This was an increase from the 1.4 million that was reported in the previous year, which is 2019. TB preventive treatment, also called TPT in abbreviation, increased from 1 million in 2015 to 3.6 million in 2019. But this positive trend was reversed in 2020 with a 21% reduction to 2.8 million for 2020. It is important to note that the onset of the COVID-19 pandemic has reversed the gains that have been made over the years in the management of TB and TB/HIV. That because most of our essential TB and HIV services were actually affected. The global community is mostly off track in terms of attaining the set TB targets, although there are some successes that have been recorded in some countries and regions. In 2021, World Health Organization and partners made a call to activity, that is the global drive to scale up TB prevention. The TB/HIV global situation, worldwide, we've got almost 38 million people who are living with HIV, and 36 million of those are actually adults, with 53% being women and girls. Of these, 20.6 million live in Eastern and Southern Africa. That is 55% of the total. And approximately 1/3 are co-infected with tuberculosis. Of those who suffer TB-related mortality, 31% are HIV infected. 1/3 of cases are actually not notified, and many patients do not even receive drug susceptibility testing. Global case detection rates remain suboptimal at less than 70%, and only 25% of MDR-TB cases are currently diagnosed. In South Africa in 2019, we accounted for 14% of the global total cases that were initiated on TB preventive therapy, which was the third highest in the world at 509,762. We have a high burden of HIV-TB infection in the country. An estimated incidence of about 360,000 cases of active TB was reported in 2019. This is a rate of 615 per 100,000 population. It is also estimated that 14,000 people became ill with multi-drug resistant or rifampicin-resistant TB in 2019. It is important also to note that TB continues to be the leading cause of death in our country. In 2019, a total of 58,000 people died of TB in South Africa. and 36,000 of those are estimated to have been infected also with HIV. The total number of deaths due to TB increased to 61,000 in the year 2020. An estimated 80% of the population of South Africa is infected with TB. That is more latent TB than active TB, mycobacterial infection. The highest prevalence of latent TB infection was estimated at 88%, and most of those individuals are aged between 30 to 39 years of age and mainly live in our townships and informal settlements. TB in HIV positive patients leads due to suppressed immunity from the HIV infections are more likely to develop active TB than those with normal immunity. An estimated 50 to 60% of HIV positive people infected with TB will also go on to develop active TB disease. TB can occur at any point in the course of progression of HIV infection. That is, you can get TB even if you are newly infected or if you have even a very high CD4 count. Diagnosis of TB in people with HIV using sputum-based tests is challenging due to the fact that most or some of our HIV infected clients have extrapulmonary TB, possible ciliary pulmonary TB, or even the inability of such patients to expectorate or produce sputum. TB HIV co-infected clients also have an increased mortality due to rapid TB disease progression and the late diagnosis and treatment of tuberculosis in these individuals due to their suppressed immunity. We also have suboptimal diagnostics that contribute to poor outcomes from HIV associated with tuberculosis. MDR-TB is 3 to 4% higher in HIV-positive patients with newly diagnosed TB. Rifampicin monoresistance is more common in HIV-infected patients and may be due to the malabsorption of anti-tuberculosis drugs in these patients. So now coming to our topic of the day, TB preventive therapy. What is TB preventive therapy? TPT is preventive therapy against tuberculosis using one or more TB drugs. As we know in the country, the most commonly used drug for now is isoniazid. This is given to individuals who have latent TB infection to prevent progression of latent TB infection to active TB disease. TB preventive therapy will reduce the risk of TB by 64% in patients with a positive tuberculin skin test, that is confirmed exposure to TB, and by 33% overall, that is irrespective of the TST or whether it's positive or negative, that is especially in individuals whose TST status we don't know. We know that there is a 33% reduction in TB in these individuals. There is no increased risk of INH resistance developing. Many tests have been, research studies have been done, and to date, there hasn't been any evidence that offering INH to these individuals will lead to more resistance to INH. So what's the difference between latent TB infection and active TB disease? Latent TB infection, the TB bacilli are dormant or latent, that is, they are not active. In active TB disease, the bacilli are busy multiplying and are active. Latent TB infection, the individual will not have any TB symptoms, they will not be infectious, and TB preventive therapy can prevent progression of the latent infection to active disease. So someone with latent TB infection is not a TB case. Whereas someone with active TB disease may have TB symptoms, may be infectious, and therefore can transmit TB to others, and TB treatment is required to cure the disease and prevent death. So this individual who has active TB disease will actually be registered in our TB register as a TB case. So in this slide, you can see on the left in the graph, there was a randomized controlled study that was done in Cape Town in South Africa amongst individuals who were HIV positive and they were on ART, and TST was not done. You can see in the slide that those who had a placebo, the incidence of deaths was higher. You see the blue dotted line compared to those who were on INH. And the Temprano study on the right at the top, you can see that immediate ART with 6 months of INH also reduced TB and deaths, including in those individuals with a high CD4 of more than 500. There was also a study done in some African countries like Zambia and Kenya, where it was also shown that enhancing prophylaxis by giving INH with cotrimoxazole and vitamin B6 as a fixed dose combination for at least 12 weeks also reduced TB and deaths from tuberculosis. The Tibella study also shows us that there is no INH resistance, even though there were high numbers, just over 20,000 cases that were given this intervention. There is no case of higher resistance due to the INH that was given to these individuals. So does TPT promote resistance? Not if active TB is excluded. TB-infected people have few organisms dividing slowly, hence there's a low risk of selecting for drug resistance. Most resistance arises from suboptimal treatment of active disease. That's why it's so important that we exclude active TB disease before we actually screen and initiate anyone on TB preventive therapy. Ongoing surveillance for resistance, of course, is required to ensure that we do not at any point cause increased resistance to any of the drugs that we use for TB preventive therapy. So how do we exclude active TB disease? TB screening in males and non-pregnant female patients. We screen for TB symptoms. So it's a cough of any duration, night sweats, and we mean excessive night sweats, not just night sweats because it's hot. I mean, like in summer now, it's quite hot at night. Most of us do sweat. Fever and unintentional loss of weight. If the patient has no TB symptoms, that is, even one, if the patient has one symptom, that patient should actually be investigated for TB. They are not a candidate for TPT. So if there are no TB symptoms, TPT can be considered after other contraindications to TPT have been excluded. So when it comes to TB screening in pregnant patients that are HIV positive, we know that the sensitivity of the TB symptom screen is reduced during pregnancy. Therefore, we do a TB gene expect on all pregnant women with a new HIV diagnosis and on all those who are known HIV positive women who have a new pregnancy diagnosis, regardless of symptoms. So we do a gene expect regardless of symptoms in these pregnant women. If the patient has no TB symptoms and her gene expect test is negative, TPT can be considered after other contraindications to TPT have been excluded and her CD4 count has been considered. Only pregnant women with CD4 counts less than 350 will be considered for TPT. This is after a randomized controlled trial showed that the use of INH during pregnancy resulted in an increase in adverse pregnancy outcomes. That is, some of the women had premature labor, there were issues of genetic malformations or low birth weight in their infants. So this is the TB screening and TPT algorithm. You can see on the left, we do TB screening. And now that we also have COVID, we also need to ensure that we are aware of what is within our COVID guidelines so that we are able to exclude both. So if we are screening for TPT, we do the TB screening using those symptoms. And if the TB screen is negative, then the individual is potentially eligible for TPT. So after this, the next step is to exclude contraindications to TPT. The contraindications are extensive peripheral neuropathy, liver disease, whether it's acute or chronic liver disease, it's a contraindication. Excessive alcohol abuse, there is actually a formula that you use to calculate if the individual is actually abusing alcohol to the extent that we cannot offer them isoniazid. If the patient, of course, is allergic or hypersensitive to INH, and pregnant women with a CD4 of more than 350, these individuals will not be offered due to these contraindications. So if there are no contraindications, we start TPT for 12 months. And we must all remember that we do not do TST anymore. TST is no longer a requirement to initiate TB preventive therapy. So if we do the screening, we look on the right, I hope that is pink or the red color, and the patient has symptoms, then they are a TB suspect, that is, they've screened positive for TB. We need to do TB investigations as per our national TB guidelines. If they are found to have active TB disease, then we will start TB treatment. If after thorough investigations, TB is excluded, then we need to investigate for other conditions. Remember, HIV positive individuals may have other respiratory diseases, they may be having cardiovascular diseases, etc. We just need to make sure that we do those investigations. And then we do not offer them TPT. We wait, we will reconsider them for TPT only after 3 months and only if they don't have any TB symptoms and any other contraindications to using TPT. So in summary, who is eligible for TPT? All HIV infected, non-pregnant adults and adolescents, whether on ART or not on ART, who have not completed a course of IPT before, and who have no signs or symptoms of active TB. Pregnant women who have a negative TB gene expect, no TB symptoms, and a CD4 less than 350. Former TB patients provided TB treatment was completed successfully, and we need documented evidence to show that this patient is actually successfully completed TB treatment. Who is not eligible for TPT? Anyone with confirmed or suspected active TB, patient who has symptoms. Pregnant women with CD4 counts above 350. Active acute or chronic liver disease. History of adverse reaction to INH, excessive alcohol use, and extensive peripheral neuropathy. Remember, with peripheral neuropathy, it is quite common in some of our HIV positive individuals, and they may be having mild peripheral neuropathy. So the guidelines are that you treat it, and only if the patient doesn't get better do you stop INH or do you not offer INH. So there is a formula that I was talking about to measure or assess if the patient is eligible for TPT. Any patient, who drinks socially. So if the individual takes more than 28 units per week and they're male, or 21 units per week for females, then they are abusing alcohol excessively and will not be eligible for TPT. So now coming to children, we need to screen all children for TB at every visit. At every time they access our facilities, we need to check to screen them for TB. That includes adults, by the way. So screening of children, this should include asking about TB contacts, contact with a TB infected person within the last 12 months, asking about TB symptoms, your cough, fever, failure to thrive, or a child who was very active but suddenly is always tired, is no longer playing, then they should suspect there is something going on with that child, and also night sweats. If there's a positive TB contact and there's no active disease, we then offer TPT for 6 months in all children who are less than 5 years, irrespective of HIV status, and in all children living with HIV up to the age of 15 years. The dosage for INH for children is 10 milligram per kilogram with pyridoxine for 6 months. In the guidelines, there is actually a weight chart for pyridoxine to help us how much we need to give the children. So with children, unlike with adults, we repeat TPT with every exposure to TB. That if there is a TB case, somebody who's on TB treatment, who's a contact of the child, then we will screen the child again and offer them TPT if they do not have active TB disease. So this is just the options for TPT options for people living with HIV from the WHO guidelines that were published in 2018. They're giving like 4 here options. I think there are 5 now. So the first option is daily isoniazid for 6 months, 9 months, 36 months. This was for all settings, high, low. And then you've got your daily rifampicin and isoniazid for 3 months. You've got your weekly isoniazid and rifampicin called 3HP. And the last one was a daily rifampicin for 3 months. So the regimen for both children and adults, we know that the dosage for adults is 5 milligram per kilogram per day with a maximum of 400 milligram per day for 12 months in adults. And for children, as I said earlier, I need 10 milligram per kilogram up to 300 milligrams for 6 months. We need to give pyridoxine together with INH to prevent peripheral neuropathy. And it's also important that we monitor these patients. So remember, most of these patients are not sick, they feel well, and it's difficult to take treatment when you are well. So they need to be mentored, they need to be counseled, to be encouraged, to be informed and educated about the benefits of TB preventive therapy. So you need to check also adherence to TPT and provide ongoing counseling and patient education, as I've just said. And you need to also teach them about the signs and symptoms of tuberculosis and early identification and management of side effects by the clinician if you identify any. And if there are any positive TB symptoms, then we need to follow the national TB guidelines to diagnose those who've got active TB disease. And remember again that TPT can be initiated on the same day as ART if there are no contraindications. And we need to ensure that TPT visits coincide with ART visits so that we do not actually put pressure on our patients to start choosing now which visit do I go to, do I just go for TPT or ART. So we need to make sure that the dates are aligned and are the same. So in summary, the differences in TPT for adults and children. For children, a child with a positive TB contact may be eligible for TPT if they are less than 5 years of age, irrespective of HIV status, or HIV positive, more than 5 years of age and less than 50 years of age. They're given TPT for 6 months, and we repeat TPT with every new exposure to a TB case. With adults, any HIV positive adult may be eligible for TPT, regardless of presence of known TB contact or not. We give them TPT for 12 months. Unfortunately, for now, until we get a new evidence, TPT is given only once per lifetime in adults. So we have a poor uptake. So the question may be why? And the challenges are that there's a reluctance of program managers and health workers due to concerns about toxicity and resistance and just a misunderstanding of the guidelines. So when we look at the evidence response, systematic review indicates that hepatotoxicity is not increased with the use of INH. Another challenge is that difficulty to exclude active TB and concern about drug resistance. There's also studies that show that there is no increased resistance to INH. or rifampicin for those who use rifampicin due to TPT. There are also operational barriers like poor adherence of clients, access to INH, and who owns it. We know INH is mainly a TB drug, so you find that the clinicians or the staff that is responsible for INH are in the TB program, and these individuals are actually HIV positive patients that are within the HIV program. So we need to ensure that TB HIV integration does happen in our facilities and we work together. And of course, we've got challenges in recording and reporting. Therefore, it is important that we strengthen our M&E systems. So other challenges, drug stockouts, supply not meeting demand, clinician fatigue, competing priorities, especially now in the era of COVID-19, and the issue of the consolidated WHO TPT guidelines, where more options, testing, and even the increase in target groups has caused confusion amongst our clinicians. It's important to note that we are still implementing the old, I don't know whether to call them old, the current guidelines haven't changed. We in the process of reviewing them, but we will not start implementing whatever is within the revised guidelines until they are approved by the National Health Council, that is the Minister of Health and the Ministries of Health. Other challenges are administrative factors, guideline changes and time to implementation at clinic level. There's also interprovincial differences, mismatch between national guidelines and clinical stationery. We know that in our clinical stationery, we do not have columns for follow-up of these individuals who are on TPT. And then some indicators, especially for completion or when the patient stops TPT for whatever reason, are not within our current national indicator data set. So we're working on this to ensure that the next needs in 2023 do have those indicators. And of course, another major challenge is the poor integration of our HIV and TB services and also our health and information services. Provider-related factors, some of our clinicians are not convinced about the efficacy of TPT drugs in preventing TB, and there's also poor knowledge of the guidelines or little confidence in actually excluding active TB in these patients. Concerns, I've said that again and again about side effects and resistance, poor documentation of TPT outcome, and low completion rates reported by some partners, mainly due to non-continuous dispensing of TPT by clinicians. We find that when you look in the clinical stationery or in whatever document, file, patient folder, the only recording is when the patient was initiated. Thereafter, it is difficult to know if the patient continued and completed the TPT or not. So what is the way forward? We need to promote agency to enhance adherence. So as healthcare workers, we need to engage our clients much more on the purpose, the importance, the benefits, and duration of TPT. We need to mentor our counselors on TPT so that they can counsel the clients on adhering to TPT. TPT info and track on patient appointment card, leaflets to sensitize patients to the importance of TPT. And we also need to conduct multidisciplinary TPT training and mentoring. It should not only be for specific managers or people who are actually involved in the program. We need to ensure that all relevant stakeholders are actually trained on TPT. That includes our managers, other clinicians, pharmacy assistants, and our data capturers. So the recommendations, we need to finalize and the revision of the guidelines, ensure that they are approved. We are in that process. We're waiting for approval or whatever changes, guidance from the NHC. And the revised TPT guideline recommendation should also allow patients on ART and TPT 15 months to complete a 12-month course of TPT. We need to report on all TPT initiations and not only on newly diagnosed HIV positive or those who are newly initiated on ART. This will ensure that it's also in our needs 2023. We know that in the current needs, we're focusing only on the newly diagnosed HIV positive. We also need to expand the TPT program to the differentiated service delivery, especially in the current environment where we had lockdowns and people not being able to move or even to access our facilities as they used to do previously. And I've spoken about ensuring that the revised needs includes indicators on TPT interruption and completion. We also need to advocate for the revision of our clinical stationery and address SCM issues, including training on stock management. Thank you, Galebo Hakenza.